Thank you, Dov. I was wondering in what city was the high school that you learned English, both of you? You must have been far away from the sea, because in Bat Yam, where I studied my high school, the sea was quite close, and we missed lots of English lectures or lessons. I went to the sea. I'll bring us all back to the ground, to the room where you sit with the patient. We'll talk about the new kid in town, about the Entresto, the new future in heart failure. I do have some disclosures. I'm medical consultant of a few companies on immunosuppression and heart failure, like Pfizer and Novartis too. So I will start with some short introduction of all what we've heard this morning. I'll talk about three cases that some of you have seen before. I'll talk about the original studies, some new sub-studies, and then I'll conclude. So we heard lots about that. Heart failure is very prevalent. We estimate something like more than 100,000 patients in Israel. The incidence is high, with probably more than 10,000 new patients per year. And mortality, despite all what we've been doing all along, remains very high. Now, we've seen this figure before. I've done some modifications to it. And so the trajectory of the heart failure is progressive, with acute decompensation episodes, and patients hospitalized here and go home, then they get hospitalized once again. And with more hospitalizations, the functional capacity declines and the mortality goes high. I've done some... we can have some shortcuts to that, and you can actually jump back again with the LVADs now, and they have 3 centers in Israel performing that operation. Actually, right now, there's a patient that has been explanted with the LVAD and undergoing heart transplantation, a patient that would probably be dead 3 weeks after the implantation of the LVAD. He was in a very sick condition, and we managed to bring him back to the very beginning, and now he's started his trajectory back again. And we hope that with the heart transplantation this morning, he'll start a new life. Also, 10 years survival of 50% with that. So actually, we are not doing that good to the prognosis of those patients. 3 case reports. We're talking about this young woman that had non-ischemic cardiomyopathy with peripartum and maybe non-compaction seen by an MRI. She has low ejection fraction, quite good functional capacity actually, on maximal medical therapy. Her physical condition is quite good. There's no any abnormalities in the lab tests, and she's clinically stable, non-diuretic. She's on ICD, and she's 36 years old, and we've seen all that trajectory common to those patients. And if you plot her data into the Seattle Heart Failure model, you get a 5-year prognosis of 85% survival in 5 years. But this young woman, we're talking about a religious woman with 6 kids, and she's 36 now. And you're really, really worried about her prognosis. I mean, if you get her on an LVAD in 10 years, then she's 46, and then she's 5 years on the LVAD, and then you put her on heart transplant, and then she gets to 55. She's quite great for a woman of 36. But nevertheless, she is still young, and you have to do something to improve her prognosis. We haven't done that very good, despite all those heart failure medications. The second patient is a quite typical patient, 8-year-old man, ischemic cardiomyopathy. He is deteriorating now, with ejection fraction that had been 30, going down to 25, worsening functional capacity. He has been recently hospitalized because of acute compensated heart failure. He got a CRTD on, he has moderate pulmonary hypertension, maximally tolerated medical therapy. He's got mild liver congestion, mild GVP, and his creatinine is starting to go down. A bit hyperkalemia, so you cannot put the Sparrow in. GGT a bit high, reflecting liver congestion. So this patient is old. Not many of those medications have been tested in the old population. His quality of life is decreasing, and we want to do something to improve that, and want to prevent the rehospitalization, and some of those medications that will not decrease his renal function. And the fourth The third case is a 6-year-old woman with ischemic cardiomyopathy for 4 years. She's been a heavy smoker, COPD, obese, with diabetes, lots of comorbidities, low ejection fraction, low functional capacity, maximal tolerated medical therapy. And then most of those medications do have some interaction with the comorbidities, so the medications, the doses of those medications are reduced accordingly. So those were the 3 cases. We'll come back to them later on. The original study, most of you have seen that study before, for those who have not. So we're talking about our way of looking, the evolution of pharmacological approaches to heart failure. We started with trying to counteract the bad things that happen, the new hormones that go up, the sympathetic nervous system and the RAS system, direct medication against those 2 systems. And then we've done quite good with that. Now this new drug with the idea that on top of contracting or blocking the renin-angiotensin C system, we can also block that enzyme that breaks down the BMP and raise the BMP levels. This is the Paradigm Heart Failure Study, a multi-center randomized double-blind parallel group active control study to evaluate the efficacy and safety of LCZ696, now Entresto. Not Ernesto, as some of the Argentinians say, it's Entresto. And compared with enalapril on morbidity and mortality in patients with chronic heart failure with reduced ejection fraction. This is the molecule. It's a novel drug. It delivers simultaneous neprilysin inhibition and adenosine receptor 1 blockade. It's a salt complex that comprises 2 active components. One is the valsartan, the good old valsartan, and the second one is sacubitril, which is a prodrug further metabolized to the neprilysin inhibitor in a 1-to-1 ratio. That was the study design. We had this run-in period where we took patients and gave them enalapril 10 milligrams twice a day. Then, open label, we gave them the LCZ and Entresto 100 milligrams twice a day. After a couple of weeks, we upraised the dose to 200 milligrams twice a day. And then they were randomized to either one of those 2 drugs, either LCZ 200 milligrams twice a day or enalapril for 10 milligrams twice a day, and they were followed up for a median of 27 months. Now, there's been lots of discussion about why the dose of enalapril 10 milligrams twice a day was chosen, and this was going back to the doses that were used in the old studies that proved the efficacy of enalapril on top of hydralazine nitrates, and a consensus in the SOLVE studies. Although in the consensus the idea was to give 20 milligrams twice a day, eventually they ended up with 18.4 milligrams per day, which is similar to the dose that we arrived at in the Paradigm study of 18.9, a little bit more than that. So that was actually quite a comparable study. The key inclusion criteria were chronic heart failure with a reduced ejection fraction below 40%, functional capacity 2 to 4, with BMP or NT-proBNP levels above 150 for BMP or 600 picograms, or NT-proBNP 100 or 100 milligrams, 100 picograms per ml of BMP, or above 400 picograms per ml of NT-proBNP for those hospitalized with reduced heart failure within the last year. They had to be 4 weeks stable with ACE inhibitors or an ARB and a beta blockers, and we encourage all the participating centers to use also MRAs, aldosterone, and they had to be stable on aldosterone for a month before the inclusion in the study. The main exclusion criteria were the history of angioedema, severe renal dysfunction, hyperkalemia, the requirement of treatment both together, ACE inhibitors and ARBs, symptomatic hypotension below 100 millimeters of mercury at screening, or below 95 millimeters at the end of an enalapril run-in or at the randomization, current acute compensated heart failure episode, history of severe pulmonary disease, or acute coronary syndrome with stroke, TIA, cardiac or carotid or other major cardiovascular surgery, PCI or carotid angioplasty within the 3 months before screening. Those are the clinical characteristics of the group. The age was, like in many other heart failure studies, about 63.8, 65 years of age. Most of the patients were males, 80% males. Ischemic myopathy was in 60% of the patients. Ejection fraction was around 30%. About 3/4 of the patients were in functional capacity 2, and the fourth in New York Heart Association functional capacity 3. Systolic blood pressure was 120, and the NT-proBNP was quite high, 1600, and the BNP similarly high. About a third of the patients were with diabetes, and most of them were treated with optimal medical therapy, just to remind us that only a minority of the patients were on devices, ICDs or CRTs. Now, this is the result of the primary endpoint, with 20% reduction in death from cardiovascular causes or first hospitalization for heart failure with the Entresto as compared to enalapril. This is very significant, and it is similar or even less than the benefit seen with ACE inhibitors as compared to hydrazine nitrates and the first studies performed. Death from any cardiovascular causes is also improved in 20% on the patients taking the Entresto as compared to enalapril. Entresto significantly reduced the number of sudden cardiac deaths as compared to enalapril, also in a range of 20% reduction. Death due to worsening heart failure is also significantly reduced with Entresto, again in the range of 20% reduction in death because of worsening heart failure. And the basic baseline characteristic of those patients that died, they were older or male, they had lower BMIs, they had higher heart rate, higher creatinine levels and natriuretic peptides, they had higher New York Heart Association functional class, and they had lots of comorbidities. There were 711 deaths in the Entresto group and 835 deaths in the enalapril group. Highly significant difference in favoring Entresto. About the components of the primary output endpoint, the first hospitalization for heart failure was reduced in the study group, and this is very important relating to what Dr. Gottesman, Professor Gottesman, in a short while, Dr. Gottesman was just saying about the companies not reimbursing patients that are rehospitalized within the first month in the United States. The drug was able to reduce the rehospitalization of patients in those 30 days after discharge. There were less patients in the study group that complained of worsening symptoms of heart failure. The quality of life improved in those patients on the study medication, and the treatment with Entresto also resulted in lower likelihood of multiple hospitalizations during the first year, significantly lower number of visits to the emergency department. Although similar duration in the hospital departments, there were fewer stays in the ICUs. There were low need for IV inotropes in those patients. Less of those patients required intensification of the heart failure therapy, and the levels of the troponin in those patients were also lower. When doing the subgroup analysis for the primary endpoint, that means cardiovascular death or rehospitalization, you see that the Entresto fared better than the enalapril in the older as in the younger group, seen here. The older patients and the younger patients did good as well, either in males or females, race or regions of the world. The study group fared much better than the patients on enalapril. Talking about the subgroup analysis, also patients in the either reduced or markedly reduced or not. Renal function were also improved on the Entresto as compared to enalapril. Patients on diabetes did better. Patients with the blood pressure either low or high did better. And the ejection fraction also in the low or the medium low heart ejection fraction did also better. Patients with atrial fibrillation did better. So the subgroup analysis showed that the drug did just as good in those patients then as in the other patients. So about the new sub-studies, In a study published last year, we saw that in those patients that treated with Entresto, the progression of the renal dysfunction was slower on the patient that treated with Entresto as compared to patients with enalapril. The influence of ejection fraction outcomes and efficacy of the Entresto in heart failure patients with reduced ejection fractions, as a post-hoc analysis of the paradigm study, you see that those increase in increments of 5, because this is how we analyze the ejection fraction in echo. We say it's 20, 25, 30, and other areas derived the ejection fraction from the Muga study, so they were more accurate. But you can see that the advantage of Entresto was seen in all the range of ejection fraction. I was much surprised and happy to see that the effect of Entresto was better also in the higher side of those ejection fraction patients on the 40% EF, suggesting that the drug might have some good benefit to those patients with also preserved ejection fraction, which is now examined on the Paragon study. Hopefully we could see that there too. So treatment of LCZ versus enalapril on tail size of ejection fraction for all outcomes, you can see that all the primary endpoint, cardiovascular death, heart failure, hospitalizations, or all-cause death, was in favor of Entresto in all the ejection fraction subgroups. Trying to examine the effects of Entresto on patients with diabetes, the group was divided in a study just published this year on patients with normal glycemia, which hemoglobin A1C below 6%, those with prediabetes between 6 and 6.4, undiagnosed diabetes as above 6.5, and patients known to suffer from diabetes. And there were, well, quite surprisingly, about 25% of the patients with prediabetes and undiagnosed diabetes and 13%. Those were in the study, and when you examined that, you saw that the effects of Entresto were similar, beneficial to all those groups in either stage of the diabetes process. So the effect of enalapril was not as good as Entresto in treating patients with diabetes as a comorbidity. So in conclusion, going back to the first cases, we've seen that the prognosis of the heart failure patient suffering with heart failure improves significantly. And to that patient that she's treated with maximally tolerated doses of medications, it could be beneficial and could increase 20% of her survival. And I think that that patient would benefit from the new therapy. The second man is an old man. We've not seen many studies with good results on benefits of our medical therapy. In that older population, this study shows benefit of the older aged man, and so he could benefit because of his age. We've seen that quality of life improved. The study showed that the medication was able to reduce the rehospitalizations and was better for those patients with renal dysfunction. So that old man, I guess, could benefit from the conversion to the new medication. And the third case is a patient with multiple comorbidities, as shown in the sub-studies that were examined lately. I think that she could also benefit from that new medication. So in Paradigm HF, LCZ 696 Entresto was compared with enalapril. It was both more effective in reducing all-cause and cardiovascular mortality and in preventing the clinical progression of heart failure in surviving patients with reduced heart failure, reduced ejection fraction heart failure. Patients who were treated with LCZ were less likely to develop worsening of heart failure, require hospitalizations or intensification of the heart failure therapy, or heart failure device implantation, or cardiac transplant. And less of them reported deteriorating quality of life. There was slower progression of renal dysfunction in the LCZ-treated group as compared with enalapril, and treatment with LCZ reduced the occurrence of primary composite outcome as compared to enalapril across all the glycemic states. And the drug was more effective and the all-spectrum ejection fraction for the primary outcome of cardiovascular death, heart failure, hospitalization, and all-cause mortality. About the safety, the superiority of Entresto over naraprib was not accompanied by important safety concerns. There were few patients that stopped the medication because of an adverse event in the study group than in the naraprib group. There was no increase in the rate of discontinuation due to possible hypotension-related adverse events, despite the high rate of symptomatic hypotension in the LCZ group. There were fewer patients on Entresto that developed renal dysfunction, hyperkalemia, or cough, and the study group had a higher proportion of patients with non-serious angioedema, but LCZ was not associated with an increase in serious angioedema. And this is my personal opinion. For whom should we revert either ARBs or ACE inhibitors to Entresto? If a patient has worsening heart failure symptoms despite optimal medical therapy, we're talking about a young patient on optimal medical therapy, and we are trying to improve their prognosis as much as we can. When there's no guideline-indicated medications that can be added, for example, spironolactone, you cannot add it. You want to do something to do better to that patient that is only on ACE inhibitors or ARBs. To those heart failure patients with multiple comorbidities that are at high risk for developing worsening of those comorbidities with the old medications. If a patient has been hospitalized because of acute decompensated heart failure, has been discharged for that, and you want to prevent the next hospitalization, and mainly for old patients that are not represented adequately in other heart failure studies. And I hope that we finished with the desert we're in, and we're going to a sunrise in the Kinneret